Good afternoon, everybody. So for those of you who are joining us by live webcast, I'm Eric Jarnagin, and I co-chair the board of directors of the Interstitial Cystitis Association. And for those of you who are here in Philadelphia, please continue to enjoy your lunch during our next session, which is Safe and Effective Pain Management, the Pros and Cons of Opioids. And it's supported by the Dan Brookoff Memorial Pain Management Fund. And my wife, Barb, and I had a chance to meet Dr. Brookoff a number of years ago, actually at an IC patient forum. And Dr. Brookoff was a compassionate clinician, researcher, and supporter of the IC community. When many doctors doubted that IC was a real condition and were often unable or unwilling to manage IC patients' pain, Dr. Brookoff believed them and gave them hope. He often said, and we heard him say this frequently, if your patient's on fire, you've got to run into the fire, not away from it. The ICA established his memorial fund in 2011 to commemorate the important role Dr. Brookoff played in progressive pain management, for which we're extremely grateful. Now I'd like to introduce our distinguished panel of speakers. Dr. Daniel Carr is a professor of anesthesiology, medicine, and public health at Tufts University, where he serves as the founding director of the institution's pain research, education, and policy program. Dr. Carr is also a member of the ICA's Medical Advisory Board and was recently appointed to the NIH Interagency Pain Research Coordinating Committee. Joining Dr. Carr is Dr. Barry Jarnagin, who is a practitioner at the Center for Pelvic Health in Franklin, Tennessee. He's a leading urogynecologic surgeon. Dr. Jarnagin is experienced in treating all types of pelvic floor disorders, including IC and chronic pelvic pain. And serving as the moderator of what is sure to be an informative session is Dr. Anna Kelly. Dr. Kelly is the medical director of the Metro Pain Center in Atlanta, Georgia. With an interest in addiction medicine, Dr. Kelly actively practices medication management to treat pain, mood disorders, and many other conditions. So please join me in welcoming them.
Good afternoon, Dr. Carr and Dr. Jarnagin. I look forward to a lively discussion on what has been, as we discussed earlier, a very controversial subject in medicine for a long time. In the late 1990s, the American Pain Society and the Department of Veterans Affairs declared pain as the fifth vital sign and instituted a campaign so that providers would document pain as the fifth vital sign, just as they do blood pressure, heart rate, pulse rate, and temperature. Within a few years, this campaign fell out of favor as we recognized that the treatment of pain, acute and subacute pain, but particularly chronic pain, is more enigmatic and difficult to treat than, say, blood pressure or blood glucose. Opioids, or narcotics, are a class of medications that treat pain by binding to central nervous system receptors that modulate pain. They, however, are not a panacea and pose issues in and of themselves that can generate suffering, tolerance to the medications, side effects, opioid-induced increased pain, abuse, addiction, and withdrawal, and even structural gray matter brain changes after as little as a month of being on an opioid. According to the CDC, there has been a tenfold increase in the medical use of opioids in the past 20 years. And another study revealed that up to 1/3 of patients prescribed opioids did not take all of them because of side effects or stopped taking them due to adverse effects or for other reasons. And these are now stored in our medicine cabinets at home, in the nightstand drawers, and are accessible to friends, families, and burglars, posing a public health problem. Some physicians regularly prescribe opioids for chronic pain, including interstitial cystitis and chronic pelvic pain, and others have a policy that they never prescribe opioids. So let's talk. The format of this discussion we'll take about 5 minutes for each presenter to introduce their position, and then I will ask questions to further clarify the issues, and then we'll have a time for audience questions. Dr. Jarnagin, please take 5 minutes or so and tell us, based on your clinical experience over the years, what is your position in the use of opioids in the pelvic pain or interstitial cystitis patient?
Thank you, and thank you for letting me be here today. I have been treating chronic pain since the very early 90s, and I have developed over the years a system of treatment and evaluation. And so one of the things that I have come to realize is that there's less segmentation in the pelvis and probably more global issues that ongo in the pelvis. And I talk frequently about the pelvic theater as opposed to segments of disease or individual things. And I find if you evaluate the entire pelvic theater and you try to find the problems that are ongoing in a particular patient, which can be either a single problem or a multitude of problems, and then gear your therapy towards each individual treatment or problem, then I find that that's the ultimate in trying to take care of that particular patient. We've heard several things going on today even. We've had the physical therapy conversation, which is vital to the whole scheme of things. And so I find that's the best way to take care of patients. And in none of the scenarios that we lay out, bladder pain, musculoskeletal pain, irritable bowel syndrome pain, vulvodynia pain, in none of the problems that we are looking at and trying to treat do opioids offer any value. In fact, as you mentioned, many times they are counter. The patient who has bowel dysfunction already, when she presents, opioids can increase the problem with bowel dysfunction. We talked about sex earlier. Most women who come in to see us have a sexual dysfunction, and we know that opioids can increase the risk of decreased libido, which the patient already has. And so most of the time, in the scenario of encounters with the patient and with the problems that the patient's having, opioids actually aggravate the condition as opposed to offer any value. And so I don't really find it useful in the treatment of chronic pelvic pain for those reasons. Now, taking it a step further, as we are now understanding this more and more, we are now moving, like I said, I started this in the early 90s, so all those patients are now menopausal and beyond. And we now know that, so there's a lot of women who are menopausal who are having chronic pain and need to be treated. We know that as we get older, our respiratory reserve is diminished, and our increased risk of falling as we get older. And opioids increase the risk of respiratory depression as well as increase the risk of falls. And so the potential risk and complications that are occurring even get higher as patients get older. And so again, for all those various reasons, I don't find it very useful in the scope of practice.
Am I correct in understanding then that you never prescribe opioids for your patients?
I do not.
Okay.
There are too many other treatment options. I mean, we talked about some today. There is a multitude of treatment options. There's a multitude of medications. There's a multitude of non-medical treatments. There's just too many good choice alternatives that can be offered to patients. And usually, again, in my experience, it's never one silver bullet that fixes people. It is a multitude of things, but you have to put all that together to get the patient moving in the right direction. And so, but there's too many good alternatives. And so there's really no need to utilize a treatment option that has a significant risk factor to it.
Thank you. Dr. Dan Carr, I understand you take a different view on the use of opioids. in the treatment of chronic pain. And so let's hear from you.
Okay, if I had to summarize an overall position in 5 minutes, I think it would, and actually I wonder if we have any of the slides available.
Yes, we do.
We often hear the term balance in relation to slides, and when people use the term balance, to me that often calls to mind the scales of justice where you have one pan versus another. But I think when we were talking about this all together, and with the three of us did have prior conversation about how to set this up with Lee and others. It seems to me balance is the right idea, but the kind of balance I think about, having been a clinician for 30 years, is more like this slide, which shows a more complex mobile. It's not a balance of A versus B, but there are many different factors. And I find myself, because I do have a background in internal medicine, thinking about many other medical conditions in which there has to be a balance of several factors, and ultimately the particular patient in front of you is the one that you have to focus your decision making upon. So if I were in a situation of treating diabetes, which in the past I had, it wouldn't only be about the insulin dose or whether to use insulin or an oral agent. It would be gauged on several different dimensions of how the patient presented. Did they have end organ damage? And what was best for the patient? By the same token, I could use analogies in diabetes management, in oncology, in infectious disease like HIV, where there's a lot more to it than just the selection of one drug. And if I were sitting here as an oncologist, I think I wouldn't feel like I was advocating for a particular chemotherapy drug, but I would say that there is a host of drugs available. So I'm really in agreement with you. There's a host of options available. And I would say you need to select what seems most suitable for the patient. I find myself agreeing with a lot of what Dr. Jarnagin was saying, and I also find myself in agreement with the American Urological Association guidelines for the treatment of painful bladder and IC, in which they reviewed the evidence very, very carefully, all the published evidence, very, very rigorously, and they arrayed several different steps that they recommended. And the first step for pain treatment had to do with education and non-drug measures, and I totally would endorse that. But the second step was based on an observation that they said there's no question that many people benefit over a prolonged period of time from opioids. And unfortunately, I think they used the term narcotics, which is a bit of a pet peeve, because narcotics, that word, it has a very negative connotation, and it's a legalistic word. If you look at textbooks in pharmacology, when they're talking about things like morphine, they use the word opioids. It's more of a pharmacologic term. Nobody's proud of taking a narcotic. It just doesn't work that way. So I would say that if you look at the totality of evidence for different treatments, I am not advocating using an opioid as first-line treatment. And I would be suspicious of any physician who said an opioid is first-line treatment. But after you have tried things that are first-line treatment that are non-invasive and have a better risk-to-benefit ratio, I believe opioids belong in the mix. And I really would recommend, although at times it's technical, that guideline was obviously done with a lot of care. It arrayed all the evidence. And not only did it describe what the nature of the evidence was, but for each thing, they gave a judgment as to the risk and benefit ratio. I also want to take a little time out, or shout out right now to Dan Brookoff, who I was privileged enough to know, who I think was an exemplary physician. And I think he had a similar view. So my view is as follows. My view is that I would not advocate, and I would be suspicious of anyone who advocated opioids as a first-line drug. But if you look at the treatments that are available out there, let's choose one that's just out of, as an example, that's got no controversy, amitriptyline. It's an old-line tricyclic antidepressant. That can actually be fatal. It can affect cardiac conduction. It can cause a number of adverse side effects. Many people who are started on amitriptyline are unable to take it at a therapeutic dose because of the side effects. And so if I step back and just look at the medicines as pharmacological agents, I would say opioids should be in the mix. But I don't want to conclude without saying that I recognize, as do many pain organizations, that there is a public health epidemic and a crisis going on because of an unforeseen consequence. I actually was there in the 80s and the 90s when well-intentioned colleagues felt that there was undertreatment of pain and that there should be greater flexibility in providing pain medication for people that would benefit by it. I can say it was an unintended consequence that there would be an epidemic of diversion and misuse, but I think anybody who's realistic has to be impressed by the statistics that Drs. Kelly and Jarnagin have laid out. So I think we become much more sophisticated in how we approach opioids. We have to only apply them, in my view, within a context of multidisciplinary care. And by the way, as I said earlier, it's the same way I would approach if I had a relative who had cancer, needed an oncologic consult and treatment, or diabetes or HIV. I think with certain of these conditions that impair quality of life, that set the person up for many adverse events, I would recommend getting treatment only if there were an infrastructure that could deliver the necessary services, so that if I had diabetes and my vision was not so good, which is a complication of diabetes, there was already in place some referral route so I wouldn't have to reinvent the wheel. So I'll stop there. I'm going on.
Might be time to go to the next slide.
Okay.
And this is a article that I recently read. It just recently came out, and it kind of talks about some of the concerns and issues that are raised. And I think one of the things, and we had this conversation, one of the things, I don't know that patients understand the risk involved in taking medications, in particular in opioids. And if you look at this, you can see that while Americans constitute less than 5% of the world's population, they consume 99% of the world's supply of hydrocodone, which simply means that as Americans, we prescribe and take too much hydrocodone. Now, one of the points that Dr. Kelly made earlier is the prescriptions in the cabinet. And what is not on this slide, but it is on the full article, which I think y'all have access to, over half the patients that took opioids they were taking them from a friend or relative, the ones that were taking it without a prescription. And so they were getting into their friend or neighbor's cabinet to take medication. And that patient got it from a physician. And there was a lot of conversation over the last several years over doctor shopping. And this article pointed out that there's not a whole lot of doctor shopping, at least in this particular study, that most patients were getting their medications from one physician. And so this is a societal issue that the responsibility and accountability is on both sides of the coin, I think. The other thing is the number of deaths are increasing from accidental opioid poisoning. And so while I would agree that there are risks in taking amitriptyline, not too many of those risks lead to dependence, tolerance, the heightened sensitivity, and the risk of death that opioids potentially cause. And the problem is, as of today, we don't know who is going to have a problem taking it and who is not. It is a problem that goes across the board, across economic lines. And so we don't know. We can't pinpoint who's going to have a problem with it. And then, at least in my world, now I'm taking care of a patient who has a physical dependence on opioids and a physical dependence or a physical problem in their chronic pelvic pain, which is, by the way, multifactorial, which is complicated enough, and now I've added yet another complicating factor to my treatment. And that's where some of the issues that I see come from.
Dr. Carr, can we talk a bit about the different opioids in the delivery systems? And also, I was so moved by what you talked about this morning when we were discussing the panel, when you said what success looks like in a chronic pain patient when they've taken opioids is they'll say something to you like, "Thank you for giving me my life back." So if you could touch on those 2 points, what does success look like and what are the different forms of therapy? Oh, and if you want to mention a couple of your favorite opioids, that would be, for use in patients, that would be wonderful if you have any.
Okay, well, it's a big shopping list. The first thing I want to say is that I respect all the points Dr. Jarnagin is making, but the current standards of practice for any pain medicine physician involve what you might call universal precautions. In other words, because of the fact that it's very hard to predict who will go off the rails with opioids. And by the way, it's not completely impossible, though. There are many risk scales out there and questionnaires that allow you to stratify that risk. But that being said, the current standard of practice is to anticipate that problems may arise and have an opioid agreement dictating the terms under which care will be provided so that they're all spelled out from day one. And that is the current practice. So this problem is recognized. In addition, I would be remiss if I didn't mention that the federal government has initiated in the last several years a strategy for risk evaluation and mitigation within which all the producers, the manufacturers of opioids, have signed onto. So there has been recognition of this problem, and I would say that the outlook is different than it was 10 years ago. Okay, let me just, in random sequence, remind me if I don't touch something. Opioids as a word mean compounds that interact with the receptor that morphine interacts with on the surface of a cell. And so there's a whole family of morphine-like opioids. Then there are some which bind the same receptor, but no matter what dose you give, they don't give the full result at that receptor. And those have a technical term called partial agonists. Those are the things when people hear about someone being on Suboxone or buprenorphine, that's what buprenorphine does. It occupies that receptor, so it means newer extra opioids that are added on can't access it, so it kind of keeps it rumbling along at a sort of half speed. And that's one of the more common ones you'll hear about. There are others that are very uncommon, and they're more like for pharmacology, where it's been recognized that the morphine receptor is not the only opioid receptor we have in our body. And there are other molecules that activate different receptors than the morphine receptor does, and which block the actual morphine receptor. And basically, you don't want to be messing around with them, because if someone's been taking morphine or anything like it, like fentanyl or methadone, and you give this newer thing and you add it in, they can get a withdrawal or abstinence syndrome. So I'm just saying that to be kind of thorough. The major ones are morphine and morphine-like. You said my favorite opioids. I would say in this day and age, my favorite opioids are the ones that are made so as to be tamper-resistant. And if you'd asked me 10 years ago, was there a market to invest in technology for tamper resistance, I would have said, I didn't think so, because most people are fine. But it's that diversion prospect which has mushroomed and mushroomed into a societal issue that makes you stop and say, well, at this stage, we really need, if we're going to prescribe opioids chronically, we really need to shift over to technologies that prevent or largely prevent the ability to crush, dissolve, or extract with alcohol. FDA is very much aware of this, and if you follow the different approvals for one drug or another, often this hinges on whether or not they can be tamper resistant. It's no longer enough right now to have a perfectly sterile, perfectly safe, well, under controlled situation, perfectly regulated product that's a generic version of some opioid on the market. In general, that will no longer be approved as of 2013. There has to be an abuse resistance. So my favorite opioid is a category, and the category is tamper-proof or abuse-resistant.
Can you speak, or do you care to speak on the different preparations, oral preparations versus transdermal patches versus lollipops, or we could take a whole hour and talk about that, or Is that more irrelevant to you than the class of opioids that you're prescribing?
No, it is relevant, and I'll speak. I don't want to take up the time, but okay. The general approach that most pain physicians will follow is, and don't forget I'm talking about after other things have been tried, like non-drug therapies and non-opioids. If you're at the stage of considering an opioid and you have evaluated the patient, you've looked at psychological risk, you've looked at alternatives and so on, after you've done all of that and you're now selecting an opioid, you make an estimate about where the pain is likely to be 24 hours a day. If the person's pain is such that there is a 24-hour-a-day component, you would use something that would cover most of that pain. So that would be a controlled release, whether it's an oral tablet or a patch that you wear on your skin. In general, you don't try to dose that controlled release such that it covers every little peak of pain, because to cover every peak that might occur, you're going to have to give such a high dose that you'd get into exaggerated side effects and tolerance. So if a person's pain has a 24-hour round-the-clock component and a few little breakthrough episodes, that's when you would use a rapid-acting medication just for those quick onset, quick offset episodes. Now, many people with IC, as we've heard today, do not have the 24-hour-a-day component, in which case I would say there's no reason to feel you have to administer an opioid around the clock if there's no pain. So that's how I would, and in terms of whether to use an oral or a patch, I would individualize that. It just depends on the individual circumstance. Do they sweat a lot? Do they like to swim in a swimming pool? If that's the case, I don't think a patch is going to work, even if you put tegaderms and barriers over it. It usually doesn't work out. I want to make one last point, because I don't want to be monopolizing the conversation. I totally respect the epidemiologic mass data findings, but I've pointed out previously that in general, a person wouldn't be seen by a pain specialist if they weren't an outlier. If their problem was simple and responded to the routine guidelines, there would be no need for a consultation with a pain specialist. So the pain specialists are in a situation where they're taking care of outliers in a world where the rules tend to be dominated by group means. And this is a big debate. It has to do with even Obamacare, like who gets what? And if you set up rigid guidelines based on group statistics, what do you do with the outlier? And what do you do if the only patients you see are outliers? So I think people are waking up to the fact that we need to deliver medicine at the end of the day that is individualized. And for some things, it doesn't matter. For some things are so great and so effective. Certain antibiotics or local anesthetics are so reliable, you don't need to personalize them. They work in everybody. But there's a lot of other medications that we're just beginning to learn how differently people respond. We already know there's about a 10-fold difference in what dose of an opioid is required by people who look the same and who just got the same operation. And if you hook them up to a patient-controlled analgesia and say, we're doing a study, control your pain, just spontaneously, they'll have a 10-fold different variability. We're just beginning to learn about that. I'm doing too much of the talking.
Yes, thank you. Very clarifying.
I think there are there's some lack of understanding, and we have gained understanding over the last 20 years in patients with chronic pain and interstitial cystitis. I mean, there was a point in time where, patients were, kind of, well, you treat your bladder, you treat your bladder, you treat your bladder. Or then there's the other segment of the population who have endometriosis and they go for laparoscope after laparoscope after laparoscope. And I think we now have come to a point in time where we understand that there's a lot of overlapping disease. And because of that, we now have a greater understanding of how to treat and take care of those patients. So I would argue that probably there's not a single quote-unquote outlier in this audience or nationally. I think what it is, it's those patients are patients who have not been adequately diagnosed, worked up, and treated for their primary pain. And I think that, it's almost, the scenario that I'm hearing, it's almost, well, after everything else has been tried, we do this. It's like the last resort type of thing. And I'm not convinced that that is really accurate, at least in my world. There are always avenues of treatment. And again, it gets back to treating the patient where she hurts. And opioids tend to just treat generically a pain that the patient has. And I think more scientifically we need to go for where does the pain hurt. And there are plenty of avenues of getting to that spot, whether it is treating the irritable bowel disease, or whether it's treating the bladder disease, or whether it's treating the vulvar disease, or you pick where the muscle disease. Make sure, I'll plug this, make sure that, and again, I think somebody said it very eloquently earlier, there are a lot of difficulties in taking care of patients with chronic pain, and there's a lot of difficulties in the patient who, by the time they get to see one of us, they're 5, 7, 10 years into this. And so, of course, they have a significant degree of depression. They have a significant degree of difficulties with relationship issues. And those, too, have to be addressed. And you have to treat the whole patient. And you treat you give the patient the tools for coping mechanisms, and you treat the patient's depression along with treating her physical problems as well. And it is if you treat the patient holistically, then, and you really dive into, okay, so we treated 80% of your pain, there's 20% left, where is that 20% left at? Let's go find that. Where is that pain coming from? And now in my world we're dealing, we know a lot more about pudendal neuralgias and the peripheral nerve side of all this as well. And so now we have other ways of treating those kinds of pains. And so there are a multitude of treatments, and I think there are safer and better alternatives that actually treat the problem as opposed to just kind of having I don't know what else to do for you, so here is this. And I think that's a disservice to the patient. I think we can treat the patient better. I've never seen a patient that I can't figure out where the pain is coming from. Now, helping the patient is more difficult, but figuring out where it's coming from, usually you can figure that out. And then you devise an individualized treatment option for that particular patient. But I was struck by and our worlds are totally different, other than being up here on stage. Pain management from an anesthesia pain physician point of view and pain management from a urogynecologist point of view are really different. But I was struck by if you're going to do this, then the recommendations are that you already have to start thinking about how you're going to treat the patient who does become dependent or tolerant. So you're already having to take care of, whereas if the amitriptyline doesn't work, you stop it and there's no real difficulties. If the gabapentin doesn't work, then okay, you can back off of that without too many difficulties. But when patients have develop a dependence on an opioid, that raises the bar. And one of the risks of relapse is stressors, which we have to deal with patients who have all stress. And the other is repeated cues. Well, every patient with interstitial cystitis tends to have flares. And so there's a repeated cue to drive that patient, potentially at least, back to relapse if they are a patient who has dependence. And so, again, I don't disagree with what he says. I just think you never have to get there in patients with chronic pain because there's too many other avenues.
Let's please make a distinction between opioid tolerance, which most people will require higher doses over time as the body becomes tolerant, opioid dependence, and opioid addiction. Who wants to take that one on? Because they're three very different things.
He's probably...
Okay, I don't want to hog the state, but when people talk about the tolerance to an opioid, as Dr. Kelly just mentioned, it just means that some, not all people, but some, require a higher dose over time to achieve the same effect that they did on day one. And that's not only restricted to opioids, you can see that with other types of agents. Dependence means that the body expects to see another dose of an opioid soon, and if it doesn't see that, it will go into an abstinence syndrome. Dependence is not really a psychological thing. If you define it pharmacologically, you can induce dependence very reliably in lab rats by just implanting a controlled release morphine in them, and their nervous system will shift into that position. Addiction refers to an abnormal behavior where operationally, I would operationalize that, where the quality of life of the person is impaired because of wanting to get more drug, preoccupation with the supply of drug, craving more drug. If the analgesic effects were working properly in a person without addiction, the quality of life would be improved. That's what Dr. Kelly referred to. We were conversing. I've had patients say, "Oh, you've given me my life back." When you drill down on that, what does that mean? It means they can do the functions either as a worker or family member or parent or spouse that they would like to do that were impaired. If they can be restored to that, even partially, then the person feels like their life has been given back to them. So the different things that happen with an opioid, I think, open one other question. I was impressed by Dr. Levesque's talk about how stigma is a huge part of pain, and especially with IC, with related conditions like vulvodynia, things that are embarrassing to talk about and create difficulties. I believe that pain itself is only partially the intensity of some painful stimulus. It's true, it is that, but we're learning from studies of people's brains that the social disconnect and isolation and shame are a huge part of pain. And if you think about it, I believe, I'll tell you what my favorite analgesic is. I should have thought of this. I have a slide of this. My favorite analgesic is when a mother takes the crying child, kisses it on the head, kisses the boo-boo, it's forgotten about, there's no side effects, it's the most widely used analgesic. It has nothing to do with analgesia. It has to do with social comfort. And the amount of stigmatization of people with pain by their surroundings and peers, as well as themselves, to me is a huge elephant in the room. So if one adds on the stigma by using words like narcotics when you could use a word like opioid, or talking about group statistics of criminals, when you're actually dealing with someone who's not a criminal, who doesn't have a high risk for addiction, I actually think that makes the whole situation worse and creates more distance between the care provider and the patient.
Thank you. I just want to, Dr. Jarnagin, ask you about your use of the term when you say risk of relapse. I presume you're specifically referring to patients that have been identified as having the disease of addiction in addition to chronic pain, and they're going to relapse on narcotics once they've had a period of abstinence. Is that what you mean by that word?
Yes, but it also gets into dependence as well. So physically dependent and or addiction, depending on how you want to describe it.
Thank you. Now, Dr. Jarnagin, I've been impressed with your ability to piece together what appears to me to be, from talking to you, a multidisciplinary practice where multiple therapeutic interventions are performed. And this is no small task in private practice American medicine. Dr. Carr, I notice you practice at Tufts University and have at your disposal a physical therapist across the hall, I presume, physicians of different disciplines. I want to acknowledge that that's a little more difficult out in private practice, and I was wondering if you could talk with us a little bit about, Dr. Jarnagin, how you did that. I think it's obvious to us all why you did that. You could see that there was a need for it. And where you'd like to see that grow, because that seems to be the cutting edge of integrative and integral medicine that we're all three in favor of.
Well, I think it's very intentional. I mean, you have to, and it kind of gets to some of the things that I think we were talking about offline a little bit, in that, you know, when you are looking to try to find a provider to take care of you, you don't want to find what I describe as dabblers, people who kind of sort of take stabs at it. You want to find somebody who they really want to try to fix the problem, and you want to find somebody who sees the problem and who can evaluate and get you to the right places. And I think first of all, it's finding somebody who is passionate and interested in the area and has an understanding of the anatomy and physiology that goes on. Because if you don't understand the anatomy and physiology and how the pelvis works, again, looking at the pelvis as the pelvic theater, looking at how all the nerves within the pelvis integrate with each other. I worked with a neurologist who I got to speak at Grand Rounds in their neurology department, because he said, you know, neurologists don't know that there are nerves in the pelvis, you know, because they're trained in so many other different ways. But so it's intentional, and then it's a matter of finding those people with expertise that are also equally as passionate and understanding and needing. And so you find that pelvic floor physical therapist. You find I've got a psychiatric nurse practitioner that I work with who has a passion and a compassion towards patients who have chronic pain, and understands that the pain is truly in the pelvis, but the coping that needs to be and everything else that she can help with. And so you put together your team, and then those that so you have those that are in-house, and then you also have the consultants. You know, we do a lot of irritable bowel treatment within our four walls, if you will, but we also have a gastroenterologist who specializes in irritable bowel when we need. And I have a Dr. Carr-like person not too far, you know, right down the road that we utilize. And so you find those people and you connect with them, and you ensure that they're all on board and kind of understand kind of what you want to do and what you want to accomplish. But you have to be very intentional about it.
Yes, I agree. That's been my experience too. I thought at this point, I hope you found the questions useful, but I thought we'd open up to the audience a few questions. And let's see, there's a specific way to do that. So I believe Anita is going to read the questions that have been submitted.
Yes. We have one question from the audience. How effective is the use of cannabinoids in managing pain associated with IC?
We're all looking to you, Dr.
Okay.
Carr. if you could say what a cannabinoid is.
Okay. Many drugs that people have used for years, have stumbled across in nature, work because we have targets in our body that were already there for substances that our body makes. So when we talk about morphine receptor, we make compounds in our own body that hit receptors that morphine hits, but they weren't there waiting to be treated with morphine. It's because we ourselves make them. We also make compounds called endocannabinoids that hit a cannabinoid receptor, which means the receptor that is activated by marijuana. So marijuana has mood effects, it has analgesic effects. A lot of people don't realize this. Even the non-steroidals that we take, they actually have an interaction with cannabinoids because they are inhibitors of enzymes that degrade things, and that includes cannabinoids. So I cannot, as I sit here, name a particular reference study, although I'm happy to look that up, but there is, in general, a lot of pain literature that suggests cannabinoids have a role in pain. They don't seem miraculous. They're not a wonder drug, but they're on that list of things that you can try to address one target while you're already using things that hit other targets. And that's the same way I think about opioids as well. I also want to say one little sentence about this, that we are sitting here for the sake of having a dialogue and not getting bogged down in technical things.
Yes.
We're talking about pain and painkillers, but there's a lot more to this. You've heard today about muscles as the origin of pain, nerves as the origin of pain, inflammatory pain, non-inflammatory pain. So there's a lot more to this that we're not doing justice to just by virtue of the time constraints when we say there's pain and there's painkillers. what we try to teach about in our program at Tufts, which you can look it up by Googling Tufts and pain, is that there's many different types of pain, just like there's many different types of infection, and you try to figure out what's the cause, like Dr. Jarnagin was saying, and match what you're doing to that cause. So it's not just like you have pain, take a painkiller. It's much more to it than that.
So next year, I think we'll probably have to have a 4-hour panel discussion.
I think if I can add, I think there was a recent study that looked at, but not necessarily in pelvic pain, but in general, and they questioned whether marijuana in particular had any effect at all in pain.
Yeah. Always when someone asks you a question, does X work? Could be, does acupuncture work? You got to say, well, hold it, time out. You need to reframe the question.
Yes.
It's, does it work for what, and what type of what, in which type of person? And that's the same exact answer I would give for acupuncture or something. There's more to this than just it works or it doesn't work.
And that's why I'm so excited about the MAP studies, because they're dividing us up into these subgroups. I think we have time for one more question, or perhaps two, if it's a quick one with a short answer.
Here's another question from the audience. I'm afraid to discuss with my doctor and family that I want to try opioids for my pain, without them thinking that I want to be an addict or I may become an addict. How do I address the topic of opioids with my family, friends, and doctor?
Excellent question. We mentioned earlier that pain is a stigma in our society, and opioids are also. Dr. Jarnagin, being that you tend to say, no, I'm not going to prescribe that, I think you might be able to answer that question.
Well, I think, first of all, I think you got to have a relationship and be able to ask the questions. You need to communicate with your physician, even if you're concerned, you have to have that conversation. Now, with that being said, whoever that is, I think you have to have the conversation with an open mind. And I'm also, I do Uro-Gyn, so I have patients who are desperate, quote unquote, for a hysterectomy. And I talk almost all of them out, particularly if it's for pain, because rarely ever is a hysterectomy helpful in chronic pain. There's a segment, but only that segment. And so it's the same kind of thing. I have to be knowledgeable enough to be able to have a conversation when the patient brings it up, as to say, I understand where you are, I understand you feel desperate, but here's what we need to do, and here's how we need to approach it. And so while I wouldn't necessarily, while I don't use them, I don't necessarily, take a stick and beat people. It's one of those, it's an educational process. It is, here's what we need to do to make you better.
Great, and I think that goes along with our other sessions. Communication is key. We have time for one more question. I only take an opioid very occasionally. Therefore, I have many left over when they expire. How do I discard of them?
That's a great question.
First, I would like to ask, do we need to discard expired drugs? And for me, the answer is no. They lose only a small amount of potency each year after the expiration date. So I would like to go on record as saying that. Dr. Carr, how would you answer that question?
Well, I wouldn't go on the record saying you should hoard drugs, but I would phrase it something like, there are people who retain their drug if they think they may use it, and there may be a gap in securing a supply of something that they will likely need in the future. But I've got to say that the whole awareness of the abuse and diversion in relation to opioids has grown a lot. So the recommendations include a secure, locked place to keep them, not just your bathroom medicine cabinet, because as a pain doctor, you hear all kinds of horror stories. People will go to open houses, real estate. They're not really looking at the house. They go right to the bathroom, look at the medicine cabinet. And then, they have a whole list of houses they're going to go to, that open house. So you hear all kinds of horrible things that happen. So if you were going to keep a residual supply, you would want to keep that in a really secure, locked location, and I'm not advocating it, but people have been known to do that.
And if a drug expires in April of 2013, it doesn't automatically go bad in May of 2013, so we can reassure our patients that it's okay to hold on to them past the expiration date.
Yeah, it depends on the drug. I mean, I was involved in pharma for a while. There's a whole elaborate series of drug testing, temperature dependent, oxygen dependent, depends on the molecule. Having said that, people have excavated urns from the bottom of the Mediterranean that have been there for 2,000 years, scraped the insides, put them on a mass spec, and found opium derivatives. So they're pretty stable if they last under the ocean for a couple of thousand years.
All right.
And we have a lot of the do's and don'ts of opioids in our latest ICA update, which I think you all have at your table. Thank you so much for all of your questions and answers, speakers.